So Heather, just before you take the podium, it's all about me and my relationship to the various speakers. I was prior to arriving in '89 at the same time as John, I was a pediatric resident, 86 to '89. It gave what was a rather feeble resident research project presentation, and Brock McMurray, one of my heroes and mentors, came up to me afterwards and said, you know, congratulations on the presentation. Didn't really look me in the eye, but told me that the best presentation he'd ever seen was a young woman named Heather Dean, who had preceded me by a year or two, who, and I don't even know if you remember this, Heather, it was embryogenesis, and it involved some sort of stalking over your head. You did this sort of a interpretive dance of an embryo, and it was a, what's that? Still using props, absolutely. The best one he ever seen, so no pressure. Let's see a follow-up to that one. Thanks for coming. Thank you very much.
Miigwech, merci, and thank you, Alex. It's an honor for me to be here. It's a particular honor for me to be here during the Henry G. Friesen International Prize. Henry, thank you for believing in me, and thank you for being an incredible mentor. So I'm just going back for a second. I want to be able to inspire the young investigators in the room to think beyond the simple diet and exercise in chronic disease, and to think new mechanisms, particularly early life determinants. I hope you have a chance to read my abstract, because that's the essence of what I believe a lot of the future of chronic disease will take us. I also want to let you know that I do 50% clinical. I was 24/7 on call, then 1 in 2, then 1 in 3, recently 1 in 4 on call, and have a very active clinical practice. It's all about curiosity and identifying things that don't fit, and then taking them and working with people who do have expertise in certain areas to develop ideas. My disclosure has to do with a story that starts down the road. I grew up in Napanee, Ontario, traditional Mohawk hunting ground, listening to my father's stories as working as a fur trader in northern Manitoba, northwestern Ontario in the 30s, working for the Hudson's Bay Company. I was fortunate as a fourth-year medical student to go to Moose Factory in my pediatric rotation, and met Johnny Blue Boy. Johnny Blue Boy made this exquisite tamarack goose. He told me a lot of stories, and there's a picture of Johnny Blue Boy and myself telling me stories from the perspective of an elder and Aboriginal health. I moved to Manitoba in 1978, and in 1983 saw the first child ever described clinically with type 2 diabetes. So it spawned 30 years of traveling up north and listening to many, many people while I did clinics with children who have type 2 diabetes in northern communities. My talk is going to be unabashedly Manitoba-centric, and I'll tell you why. The Canadian Pediatric Surveillance System allowed us to do a national study of incident cases of type 2 diabetes in 2004-2006. As an aside, this data is now almost 10 years old, and we're just planning another one, pan-Canadian. We thought that type 2 diabetes existed across the country. We didn't know how it was significantly a Manitoba problem. If you take the children that we see from northwestern Ontario in the pediatric diabetes clinic in Winnipeg off of the Ontario bar and add it to the Manitoba bar, because the Ontario bar was very tiny, the northwestern Ontario children, we were 20 times greater than any other place in Canada. And what was interesting was that although there were a few Caucasian children and the traditional minority groups who have higher rates of type 2 diabetes in adult populations, in our survey of incident cases, 44% were Aboriginal, First Nation, and Métis. And what we noted was that these children were younger, more often female, had less clinical expression of insulin resistance as described by in the polycystic ovary syndrome, or PCOS, and dyslipidemia, and were leaner than children of other ethnic groups in Canada. And furthermore, of the 44% of children who were First Nation, 75% of them were from Manitoba or Northwestern Ontario. I used to say, if you look for it, you'll find it. I stopped saying that 20 years ago because you'll only find it if you look, and you'll find it at lots in Northwestern Ontario, the Sioux Lookout Zone, and Manitoba. This is the area that we see our clinical population from. As I said, if you see something that doesn't make sense, you start counting, and literally bean counting. So we saw our first case in the mid-1980s, and our database, our clinical database, started in 1986. The number of children that I saw with type 2 diabetes was very small, 1 or 2 a year, and then it started growing. And the last 3 years, the number of new cases of children referred to us with type 2 diabetes exceeds the number of children with type 1 diabetes, which is a remarkable phenomenon not seen in too many places in the world. These children are not doing well. This is a slide of the survival without complications, meaning that only 25% of our children do not have blindness, amputation, or dialysis within 20 years of diabetes. If you get your type 2 diabetes at age 10, you're going to be on dialysis, blind, or without a leg at age 30. And this is overall survival. The black lines are children with type 1 diabetes. The red line are the children with type 2 diabetes. This is overall survival. These children are dying. Furthermore, when they graduate from the pediatric program at age 18, their blood sugar control is poor. These are the 50 youth that we graduated at age 18 in the year 2011, with an A1C of over 10% in half of them. Half of them had been admitted to a psychiatric ward for suicidal ideation or suicide attempt. A third of them had been involved with child welfare agencies, and a fifth of them had already been pregnant at age 18. 30% of them had grade 9, and 30% had dropped out of school. We knew that in our clinic, as well as in our research team, we had to understand, we had to appreciate, we had to acknowledge a socioecological framework that really brought into all of our being and how we work with our Aboriginal families the impact of colonization, disposition of traditional land, assimilation policies, residential school, and the White Paper of 1969. We had to appreciate the intergenerational impact of the challenges of geography, the jurisdictional issues, federal, provincial, the care delivery systems, food security, cultural differences, and post-colonial adaptation. One of my Aboriginal colleagues, and we work with many, says it's a misnomer and it's an insult to talk about lifestyle choices when there is no choice, when you are very poor. We try to develop authentic community partnerships in order to be able to work with our families and communities who have children with type 2 diabetes, and it worries the adults and the elders very much to see 6, 7, 8-year-olds with type 2 diabetes. This past year, we've embarked on a study that looking at the use of creative expression, art, and storytelling, not as a form of therapy, but rather to help inform our clinical practice and foster self-care. How do we help children to understand the importance of self-management, and how do we help families and communities in a different paradigm? Early on in our experience with First Nations children with type 2 diabetes, we recognized that there was significant phenotypic variation. The girl on the left is lean. Why should she have type 2 diabetes? Only obese or adults who are sedentary get type 2 diabetes. We knew there was something different in this 10-year-old who had classic picture of type 2 diabetes without the obesity. We also knew at that time, And I'm actually reminding of Dan Drucker's talk. He was starting to recognize GLP-1 in the mid-1980s, about 85, 86, about the time we started recognizing type 2 diabetes. It was also the time when AIDS was first being described as a disease, mid-80s. We knew that there were a multitude of genetic factors that were influencing the glucose sensing part of the beta cell, as well as the insulin secretory side of the beta cell. We knew that there were forms of maturity onset diabetes of the youth that have been described in textbooks for a long time. Very, very, very rare genetic forms of diabetes. In 1999, colleagues at the University of Toronto identified a very unique and private single nucleotide polymorphism of the HNF1 alpha gene, glycine to serine at codon 319, not described in any other population in the world to date. It would appear that we know it's a polymorphism, or we call it a polymorphism, because it affected 8.7% of the general population in the community indicated in red, which is Sandy Lake, one of the communities we see the children from, and very close by canoe, a 3-day canoe ride to some of our communities in the Island Lake Tribal Council. This polymorphism occurred in 21% of adults with type 2 diabetes, and a third of the individuals who developed their diabetes before age 35. They were able to calculate that for each one of the S alleles, you got your diabetes 7 years earlier. In vitro, colleagues in the University of Manitoba and University of Toronto identified that this polymorphism reduced the transcript by 66%. HNF1 alpha knockout mice show hypocetylation. Bottom line is that with this SNP, the ability to secrete insulin is reduced. So when we looked at the children in our clinical population, of whom 50% had 1 or 2 copies of this polymorphism, we identified, that the SS homozygote for the S allele was lean and had very little expression of insulin resistance. The heterozygote was in between, and the wild type was classical obese child with features of insulin resistance. And furthermore, in the red, their BMI at diagnosis reflects that picture of their phenotype. Their acanthosis nigricans, a clinical feature of insulin resistance, was very, very low in the children who were homozygotes for the SS allele. Their A1C at presentation was higher. Their fasting insulin level was lower. Remember, I said that this particular polymorphism causes reduced insulin secretion. Not insulin complete absence, like our children with type 1 diabetes, who are very, very different disease. These are children who have a reduction in their ability to make insulin. And a biochemical measure of insulin sensitivity, their HOMA was lower, i.e. they were insulin sensitive, compared to the children who were wild type. Around that same time, as we were identifying and looking at the HNF1 alpha polymorphism, we looked at some prenatal and infant risk factors, trying to understand why were children, if this polymorphism has been there forever, and we never saw expression of this disease in children, why are we now seeing it? So we looked at in a case-controlled study and found that the odds ratio of mom having type 2 diabetes before pregnancy was 14.4. Remember, type 2 diabetes didn't occur in women in the pre-productive age group 50 years ago. We also, interestingly enough, noted that breastfeeding reduced the rates, or at least was associated with a reduction in rate of type 2 diabetes. So we turned our eyes towards the exploding literature on early life determinants. A lot of animal data in rats and mice and monkeys that have showed that maternal, and also in humans related to the war, that maternal undernutrition during the first trimester of pregnancy leads to chronic disease, particularly type 2 diabetes and heart disease. That maternal obesity in pregnancy, particularly in the first trimester, causes significant higher rates of, or associated with higher rates of childhood obesity and childhood chronic disease and adult chronic disease. and that maternal pre-pregnancy type 2 diabetes, at that point only identified in the Pima Indians who had such high rates of diabetes, that maternal pre-pregnancy diabetes was associated with higher rates of type 2 diabetes in children. At that time, in the early 2000s, now 10 years ago, there was an international group that is now growing quickly, looking at the developmental origins of health and disease, or fetal determinants, or early determinants. No one's quite landed on the right topic, right title yet, and it's been all over the public media. So we turned our eye to early life determinants, and we knew that the mothers who I'd seen in the mid-'80s were now having children. This particular mom now has 5 children, 4 of them have type 2 diabetes. We started our next-gen cohort in 2003, and this is a very carefully described birth cohort where we know the mothers' clinical and biochemical characteristics during childhood, and looking at their children. And the red are the fathers who had type 2 diabetes and their offspring. The blue are the mothers, and the children who have type 2 diabetes already are in yellow. And you'll note very quickly that over the age of 10, approximately a third of the children have type 2 diabetes already in this cohort. Clearly a very, very significant impact of, we don't know what's going on because we don't have any children of any of the dads yet. The female to male ratio is 2 to 1 of type 2 diabetes in our children. So we have more mothers. We also know increasing data on the development of the pancreas. The embryogenesis of the beta cell is growing in the first trimester, throughout the second and third trimester, and we now know that the increase in number of beta cells continues throughout childhood. And a recent paradigm that we're looking at is if for some reason you're born with a lower number of beta cells, and for some reason those beta cells don't increase normally through childhood because of infant nutrition or infant disease or infant exposures, you in fact are going to have a lower beta cell mass, lower beta cell number. With that lower beta cell number, if you have any degree of insulin resistance, you can't mount an insulin response, and your risk of type 2 diabetes is much higher. Another way of saying that is asking too much of too few, meaning that with any degree of insulin resistance, you need to mount an insulin response, and if you can't, then you're going to become hyperglycemic. So we know something has reduced the ability of these children to make insulin, perhaps partly because of their HNF1 alpha SNP, but that disease was never expressed before in this population. Why now? So something else has pushed the number of beta cells or the ability of beta cells to make insulin down further. Recently in an editorial, the development of the endocrine pancreas is controlled by a hierarchical network of transcriptional regulators that requires a tightly interconnected epigenetic program to drive endocrine cell differentiation and maintain islet function. Something is changing the ability of our children to develop a normal beta cell. We have a large team now at the Manitoba Institute of Child Health that includes social scientists for the reasons I outlined at the beginning. It's incredibly important for us to work with our First Nations partners in this whole enterprise and to understand and to work with communities and families. So we have social scientists, we have clinical scientists, both pediatric endocrinologists and pediatric nephrologists. I didn't talk about the development of the kidney and what's going on in the kidney in these children who we believe have reduced reduced nephron number as well, and why they're getting into such trouble with renal failure quickly. And also basic scientists. And the paradigm we're using is the comprehensive phenotyping of complications and their biological determinants in the youth with type 2 diabetes and the birth cohort of mothers, looking at epidemiological risk factors and gene-environment interactions using specific animal models and hopefully novel targets for future interventions. So the implications of this large body of, and my life and career, has been to identify new treatment paradigms that incorporate a socioecological approach, including local traditions, language, and culture, into the science of it. Recognize that type 2 diabetes in children causes long-term intergenerational impact on family and community structures, and to perhaps push and encourage, inspire the health policymakers to focus programs on pregnant women with a critical mass of effort, resources, and funding, including research funding, to be able to understand what's going on in pregnancy and the whole world of chronic disease. With that, I just want to thank our funders, but also to thank specific individuals. Bertha Flett has been on this journey with me since the very beginning. Her daughter died at age 25 of a sudden coronary event on dialysis, having had type 2 diabetes since she was 9. She's passionate and believes very strongly in us trying to help understand what's going on in these children with type 2 diabetes. Thank you.